In the next 6 minutes, I'm going to introduce to you a transformational approach to the diagnosis and clinical decision-making of the leading cause of death and disability in the United States and globally, coronary artery disease. Our first product, C-Heart, is a non-invasive outpatient virtual cardiac catheterization laboratory that combines readily available cardiac CAT scan images with proprietary breakthroughs in the physics-based computational modeling of coronary blood flow, which enables the physician to identify coronary artery blockages that should be revascularized by a subsequent invasive procedure like a stent or bypass surgery. We'll discuss in a moment the impact that C-Heart will have on the practice of cardiology. Our technology platform is the accumulation of 10 years and over $6 million of multidisciplinary collaborative work by leaders in multiple fields at Emory University and the Georgia Institute of Technology. And on behalf of the scientific co-founders of the company, Dr. Don Giddens, Dr. Habib Samadi, and Dr. Alessandro Veneziani, we want to thank the Coulter Foundation for its support over those years that led to the formation of Covanos and the movement of this technology into the clinical marketplace. We're addressing two critical needs in clinical medicine. One, and it's the evaluation of chest pain or angina, which is the symptomatic manifestation of coronary artery disease, both in the doctor's office and in the emergency room. Today, patients with chest pain undergo a stress test put on a treadmill or an analogous mechanism to try to reproduce the symptoms and to visualize whether or not the pain may be due to coronary disease or not, and use that as a gateway to the invasive cardiac catheterization lab where a definitive diagnosis is made and a therapeutic procedure is performed to relieve the blockage if indicated by placing of a stent. Yet the consequence of this approach, because of their poor diagnostic accuracies, these non-invasive tests, of which over 11 million are performed in the United States yearly, yield globally about 3 million invasive coronary angiograms, in which the question is asked, does the patient have obstructive disease sufficient to justify the placement of a stent, or should the patient be treated medically? And we know that less than 50% of patients who go to the cath lab actually have disease that justifies intervention. So these are diagnostic caths. These are largely wasted diagnostic procedures that could have been avoided if we had something that could be more accurate as a gateway to the invasive procedure. So what do we do inside the catheterization laboratory? The question is to stent or not to stent, as Shakespeare might say. A visualization of the blockage is made by a radiograph in the coronary artery, and a pressure wire is put across that blockage by the interventional cardiologist. By measuring pressures before and after the blockage, we can determine one of two clinically validated, regulatorily approved markers of critical blood flow called FFR or IFR. The acronyms are not important. The important point is this establishes how much this blockages impact coronary blood flow, and we now know by extensive clinical trials and regulatory approaches that this has a major effect in improving clinical outcomes and reduction in costs in patients with coronary blockages. What we do in C-Heart is do all of this on an outpatient basis, not inside an operating room-like situation for the cardiac cath lab. In your street clothes, you go to a CT CAT scanner that takes a picture of the coronary arteries of your heart. They're reconstructed inside internally. And then we use advanced and proprietary algorithms in computational fluid dynamics to model blood flow across those blockages and give the physician on an outpatient basis the same answer that the interventionalist gets in the cath lab. Are these blockages of significant import that you should now go to the cath lab for a stent procedure, not a diagnostic procedure? CT angiography is becoming readily accepted and approved globally as the first-line diagnostic to assess the severity of coronary artery disease, and represents a very large and rapidly growing clinical market with over 300,000 projected C-Heart procedures presently based on utility of CT angiography for this diagnosis, and its rapid growth in the future, yielding over 1.5 million procedures for C-Heart in the US alone. How does it work? We take images of the CAT scan images of the coronaries. We reconstruct the three-dimensional geometry of the coronary artery in a PC workstation adjacent to the CAT scanner inside the hospital. This is all done within less than 30 minutes, and using these computational fluid dynamic algorithms, we overlay a functional map of blood flow on the images of blockages derived by CT angiography. The accuracy of this has been established in over 100 vessels now in 88 patients. It exceeds the diagnostic accuracy required of a clinical decision-making tool for heart disease, and addresses the needs of the marketplace, not only in its high diagnostic accuracy and clinical validation, but generates rapid clinical reports at the site in less than 30 minutes, and is a point-of-care solution in which the patient data never has to leave the hospital information technology firewall, obviating the concerns of IT-restricted major health providers such as the Veterans Hospital, all of Europe. And this issue of maintaining local control of patient data is one of our signature profile components. We're building a diversified risk-mitigated portfolio utilizing computational fluid dynamics, non-invasive imaging for a variety of vascular diseases, and with a established and well-recognized expert team of executives in the multiple disciplines necessary to build a high-tech company. We are very excited with the opportunity of making a difference in the diagnosis and treatment of coronary artery disease and vascular disease in general, both in the United States and globally. Thank you very much.